Reactive Training Systems.
Welcome to the RTS podcast. I'm Coach Mike. Man, I've got a good episode for you today. Today, I'm going to be joined by RTS coach Gaby Muller and also Dr. Nathan Dailey. If you haven't heard me talk about Dr. Nathan in the past, he is a doctor of physical therapy. He's been practicing physical therapy for nearly a decade now. His roots go back to the U.S. Army, where he was a physical therapist in the Army for, I believe, 7 years. And I got introduced to him a few years back, and he has helped me out of several jams, to include the jam that I was in prior to the 2023 U.S. Nationals that I've talked about on this podcast and on some other contexts. We'll touch on that a little bit in our conversation today. But the thing that I've noticed about working with Dr. Nathan over the couple years that I have is that he takes what I would consider to be a kind of a full spectrum evidence-based approach. We've talked about evidence-based practice on this podcast a couple times lately, and about how it's a triad model, and that, peer-reviewed evidence is certainly an important leg of that model, but it's not the only leg, and that there are other things to consider as well. I think in my experience, Dr. Nathan has really threaded that needle nicely. And we'll touch on that today. We'll talk about pain science. We'll talk about clinical experience. We're going to talk about maybe what some of the limitations of these things are, how narratives have changed over the years, and how maybe pendulums have a tendency to swing too far, and what we notice in that regard. Anyway, we cover lots of ground, most of it related to pain, rehabilitation, return to sport, return to training, things of that nature. We talk about this in broad terms, but also from an athlete's point of view. Both Gaby and I, have some pretty significant experience with injury. So we are relating to it more from the athlete's point of view and the coach's point of view. Dr. Nathan obviously is a professional physical therapist and is bringing a different set of viewpoints. I think if this is a topic that you're interested in, this will probably be illuminating in some way, that you are likely to encounter an opinion here that is different from some of the more extreme opinions that you will encounter on the internet. And yeah, anyway, enough of me talking about the talk. Let's get right into the conversation. Here's our conversation with Dr. Nathan Dailey.
Mike, I would love to start it off with your experience too. Do you feel over the last, 2016 was when you said, you know what, I'm gonna hang out the towel for a little bit and I'm gonna wait, right? I'm gonna wait out this injury and I'm gonna switch to something a little more non-specific. I'm gonna train with front squat, right?
Mm-hmm.
Do you think that waiting was an effective strategy for you?
I think there did need to be some amount of waiting. I had tried pretty much everything else up to that point, and when I would get away from things that would provoke it, for me, it was back squats and deadlifts. Like, I'd taken time off before, 2 weeks, a month. And when I would come back to normal training after that, it would be better for a session or two. And then it would gradually, the condition would get worse again. I eventually got tired of that and took a long time off. And the step coming back was, first of all, it was 6 years. I talk about this maybe too much, but it was 6 years. It didn't need to be that long. Finding momentum in the reintroduction was a challenge, a scheduling challenge as much as anything, to be honest. Just kind of getting that momentum built back up. But ever since then, I've been diligent about load management, and the more diligent I am about it, the better things seem to be, at least in the long run.
Each of those episodes when the pain came back, I guess between 2016 and let's say 2018, you tried to introduce the competition movements back in, and you said the pain would come back. How fast of a ramp up period, to kind of quote the acute to chronic workload ratio discussion, like how fast did you ramp up that stress or those arbitrary units of the training session?
I mean, training logs, so we could calculate what all the numbers are. I don't know them off the top of my head. It was a lot more rapid than where I ended up being. But like I worked with some therapists who would advocate for different things, like we I would get the pain in mostly in my glute, but it would be during the lockout phase of a squat or a deadlift. But if I avoided the bottom, then I didn't have the issue. So like I worked with some therapists who would recommend, training rack pulls and things like that. So I would do that for a while with load controlled. I would spend some time training, RDLs and doing slow tempo stuff and lots of the things that you would think to do. And it would either provoke it minorly, so it never really got that much better, or it wouldn't provoke it. And then after, a couple weeks or a month, we'd say, all right, let's see how we're doing now. And I would do a normal training session or two. And then by the end of it, it's like, oh yeah, okay, and I'm still getting the issue, you know.
Yeah.
And I think like in hindsight, I think that was a big mistake is like trying to go back to normal. I probably could have left the competition lifts alone. Maybe even for a month or a couple months again, like I had done before. But instead of going back to normal, like a more gradual ramp up uh, would have been more prudent. Maybe just try one set of back squats this week and see how that goes. Okay, one set was successful. Let's just cruise there for a little while. Like that's better than no sets. Like I'm going on too much about this, but I did work with a therapist for a while who, we were doing like ratings of pain and stuff like that. And I would go through these periods where, I'm lifting the same weight, which was really not much. We're talking about like warm up quality weights here. Um, but the perception of pain would decrease. And she would say, like, see, that's progress. And like, while I understand, yes, that's progress, like that did absolutely nothing for me. I'd rather not train
Yeah.
than do that. Yeah. Sorry. I think you were probably on your on your way to a point and I'm
No,
derailing
no,
us.
no. I want to understand that experience because I think it helps set up the context in which kind of this discussion might happen here. And I guess I see it as kind of like a pendulum. We always have this oscillation between two, oftentimes extreme and portrayed as diametrically opposing viewpoints. We'll have someone who says, the prevailing model, as you well know, and this has been gone, people have gone over this in great detail, but tissue damage equals pain. Therefore, we need to address that tissue damage in order to get the person out of pain, whether it's a therapeutic approach or it's a surgical approach. And obviously, that's been called into question and really thoroughly debunked in a lot of cases. There are many instances where, to looking at a lumbar spine MRI in an asymptomatic population, you have multiple disc herniations, bulges at multiple levels, and the person has absolutely no pain and presumably can train exactly as they want to. And then, subacromial decompression surgeries are shown to be no more effective than sham interventions or exercise interventions for relieving shoulder pain that was ascribed to pinching of the rotator cuff tendons. So, obviously the biomedical model or that, pathoanatomic model doesn't account for some of this nuance here. But the model that's kind of replaced it is, well, let's go ahead and continue to train. Let's modify our approach. Let's change the ranges of motion. Let's change the load here. Let's continue to train. Let's breed, the term movement optimism here. Let's get this person to continue to train the movement that maybe hurt them in the first place. Get them that confidence back and not get them to be very fearful of the risk or harm of injury. But I think that those kind of represent two extremes. One says the tissue matters immensely, and the other side says The tissue really doesn't matter at all. What matters is the psycho and social components of that biopsychosocial model. But I think that the marriage has to come kind of in the middle ground. And we can go into kind of some more of the details of those two extreme opinions. But I think just to summarize it quickly, I think the bio component has been thrown out with the use of the biopsychosocial model because there are so many charlatans, so many people, maybe even well meaning people, who have tried to hang their hat on tissue pathology as the cause of pain. So, what are your thoughts, I
Yeah.
guess, on that?
Oh, I'm glad you said that. Like I've felt the exact same way. Like, biopsychosocial uh, being the model, I feel like the emphasis has swung really hard in the direction of the psychosocial end of it. It's a bit of a joke, but like, oh, hey, my back hurts. Well, your back hurts because you got a bad phone call last night. Like, well, I don't know if I can put any buy into that. And it reminds me a bit of like the evidence-based practice. It's supposed to be a triad, but it's lots of practitioners are not using
Well,
it
let's
as a
go into
triad.
those
It gets,
specifics. It's the
yeah,
triad. It's the what the
right.
research says, the clinician experience, and the patient preference are the three sides of that stool. What does the patient want for treatment? What experience does the provider have treating patients like this in the past? That in my clinical experience, that bad word, right? We don't use that word. In my clinical experience. And then also, yeah, what does the research point us in the direction of? But you're absolutely right. It's almost like knocking out a couple legs of the stool and saying, you know what? Because other people have relied too heavily on the other legs of this stool, they don't matter anymore.
Yeah, and I mean, I totally am sympathetic to that being a necessary part of like shifting the narrative. And like if you have a whole community of people that tilt too far in one direction, maybe you kind of have to tilt the other direction to get any traction, in terms of like influencing a culture and things like that. But there's a big difference between influencing a culture and treating a patient or prescribing training to an
One
athlete.
is a
Like those are
sociological,
different.
like, description of a society in general, at an academic exercise, and to some extent, it's education, sure. It's putting out a narrative out there that balances prevailing wisdom before, but what do you do with that N of 1 person in front of you? That person who's acutely in pain right now, pain and training, what do? Like, what am I gonna do right now for this person right now? Like, for you, what am I gonna do to get this person stronger to me? The research suggests that lower reps are more specific to the competition and getting better. But you know as well as I do that there are lifters out there who have a very strong E1RM response and peak into competition with sixes. Would you predict that from where the research generally, the population mean is described to the control group describes? No, right? You have
Right.
to bring
And
some individualization to the treatment of the person in front of you.
and I'm a bit of a, I guess, a materialist when it comes to this stuff a little bit. So like if we stay with training for a second, just because I have more expertise there. Like, yeah, we can say that there's this person in front of us who has historically showed more of a strength response from whatever rep range. And let's say it's sixes because that's atypical, right? They have that response for a reason. It's not ethereal. It's not
No.
because, they're just some special snowflake in the universe. Like, it's not that. There is a reason why, and maybe we don't understand it.
Yeah.
Maybe we can't even measure it. That's all
No, it's
fine.
Mike, it's because you told them sixes would work in this case. You placeboed them into a strength response by really convincing them, and your authority and the provider mediated placebo effect allowed them to achieve a new PR on, meet day. That's why.
Oh, touche,
Yeah, yeah,
sir.
yeah. No, I'm kidding. I'm kidding, obviously. Like, but I want to explain that it's like the pain experience has numerous contributing causes to it. There are the psychological associations this lifter has with their prior injuries, with their parents, with their beliefs about the pain. There's this strong, contributing experience. And let's say we controlled for that in some way, and we found a person who let's say this person is just well versed in all the biopsychosocial model, and they say, you know what, I don't think my back is injured. But man, I'm in a hell of a lot of pain here. Right. So maybe it's not as high as it could be if they believe that they've blown out a disc and they're going to be in a wheelchair in 5 years, but they're still in pain right now. So there's that still that biological component to their pain experience. So what are we going to do about that? That I guess that's the question, right? What are we going to do about those local or tissue specific causes? I hate to use that term, but contributors to the pain experience.
And contributors is a good term.
Gabby, what thoughts do you have? I could talk all day, but I want to like pause and see what you have to say.
No, definitely. I feel like oftentimes it's natural that we want to talk in absolutes because it kind of shows us that things can be very simple and there's easy fixes for that. But at the same time, when you're working with people, you shouldn't forget that you have a person in front of you that is completely different than the person you've treated just before. So you really need to be open minded. But depending on what kind of injury you have, like certain injuries are very complex. So it is very hard to pinpoint, okay, this is why. And as you just mentioned, like there's a lot of contributors that contribute to a patient or an athlete in general, just how they perceive pain. And I feel like physiotherapist as well as also a coach can definitely influence the outcome, like the whole recovery process.
Mhm.
Because, for example, when I had the back injury, I've dealt with people that panicked, that told me after a while when the pain didn't go away, yeah, maybe it's time to just shift away from competition work, squatting, deadlifting, and
Yeah.
benching, not focusing on performance and just dealing with something else instead, like focusing on other things in life. But I also had people that told me, no, you can still train, keep training, and focus on performance, and it's going to be okay. And both were in different situations, and they also had different outcomes. And yeah, a lot of contributors played a role here.
Yeah, and I mean there's secondary gain there, right? I mean even if you're I guess even if you're an ethical provider, there's still an incentive to um break down the progression back to full function into smaller steps. Well, I'm sorry, your lumbar multifidus isn't firing actively. So, oh my God, we've got to do regressions of the bird dog and build you back up to the bird dog. Oh my God, your back's a mess. If you don't do these things, then I can't possibly have you under a bar. That's not the approach that we want to take either, because that pathologizes things, that makes people think that they're dependent on an external marker of success for progressing to the next phase, one determined by the provider. Oh, I palpated your multifidus and I felt it firing better, so therefore you're ready to go. That's not what we want here. And I think, Gabby, you're describing that experience of a prolonged rehabilitative process because of that focus on, well, something's wrong here and we need to address it in order to get you better. So I guess what I'm proposing here is not that we say, we need to do a microdiscectomy here, or we need to do a partial meniscectomy of the knee, let's say, to remove this tissue that's abutting against the nerve. Now, there are indications for that in the low back. Let's say a progressive motor deficit, something's getting worse progressively. The joke is you're peeing on your drop foot, you have signs of cauda equina syndrome, your pressure to your spinal cord is so severe that you could risk permanent loss of neurologic function, either to your bowel or bladder or to the muscles in your lower extremity that control certain, or the nerves in your lower extremity that control certain muscles. But we're not talking about that, right? We're talking about potentially easing this person back into training, but doing so in a way that respects that there may be local causes to their pain experience that are at the level of the tissue. And what are we going to do other than just tell them to train around the pain and wait for it to get better?
Yeah, because on one side you hear that you shouldn't be provoking the pain, and like you typically hear pain shouldn't exceed a level of 3 out of 10 in training. On the other side, there are rehab methods where you should be provoking the pain because you're just building tolerance there, I guess. Maybe you can also explain this, elaborate on this a bit further, but there's a few different methods, and I don't think there's always necessarily like one way that is the magic way to go on about it.
Mike, I can weigh in on that, but do you have any thoughts about that? Like, were you told
No,
conflicting
please.
information from different providers?
Not on that one in particular for me, For me, initially, the input I kept getting was, it was fine to train with a certain amount of pain. We would set some sort of threshold, but then try not to fixate on that threshold too much. And I think that was generally good advice. It just became exhausting for me. It was just like this. It's not fun anymore. And I want to do something else. So it was just I chose to do something else. That's kind of what drove my course change.
I think the difference in perspective, Gabby, about like pain and whether you can train into it or whether you need to avoid it, comes down to almost convention in some of the research. A lot of the research on tendinopathy specifically advocated for loading of the tendinous structure and heavy loading of the tendinous structure. Now, it's come to light that eccentrics are probably no better than concentrics, but we should probably do things with a slow, controlled tempo in cases of tendons related pain or tendinopathy. The argument went that we needed to have an adequate amount of load, and the only way we would know if we were loading the tendon enough would be to provoke a little bit of a pain response. We know we're localizing the treatment to the affected tissue in that instance. And we don't want the pain to get out of control either during the session or between sessions. But if there's no pain, how do we know we're actually treating the area? I think in the case of, let's take a competing diagnosis of like patellofemoral pain versus patellar tendon pain. Patellofemoral pain is a nebulous term. Patellofemoral pain syndrome. Syndrome means we don't know what the hell is going on. It's a constellation of findings that describe something, the patient's experience. We know in patellofemoral pain that there's an inhibition of quadriceps muscle activity in the presence of that pain. So the harder you push, and when you have pain, your voluntary contraction of that musculature is less in the presence of pain. Even if we've advised the trainees, hey, you're not going to do any harm to your knee, it just hurts. No one wants to keep pushing into pain repeatedly. So the approach to managing patellofemoral pain um, will largely try to avoid that painful response, if only for a reason of we don't want to reinforce that every time I do this movement, I have pain. It kind of is counterproductive because you're not getting the kind of muscular recruitment you want in the motion or in the movement. So it's better to avoid that range of motion or that movement that causes the pain. But if we determine that the localization of pain, let's say, is in the patellar tendon just below the kneecap, in that case, we do want to adjust our squatting position or that loaded knee flexion angle such that we're putting some load directly through the patellar tendon, then through so doing, are adequately loading it and building that load over time so that we can reduce the pain experience. So that's where I've seen the difference. But again, it seems like it comes down to convention. It's not because it has to be done this way. It's because it has been done this way.
Do you
Yeah.
feel that patients over time, the longer they are dealing with pain, the more sensitive they become to it? For example, in Mike's case, that's he's just like he already has this memory of having been
Yes.
in pain for so long that he's just fed up with dealing with that. And then as soon as he wants to get back to it and he notices after a few sessions, okay, I'm in pain again, it's not worth it. That's maybe the pain wasn't as bad as before, but maybe he feels that it's aggravated again.
So there are two things that are kind of contributing to that. It's Mike's um, personal experience with pain. Each time I had pain, it led to this outcome. I wasn't able to train. It was painful. I was fighting. There was a high cognitive load associated with trying to push through my training and achieve what I wanted to achieve. So there's that, right? That presence of pain then, we as organisms are well equipped to avoid potential harm, right? Pain is that indication that something is amiss here. So it's natural to try to avoid further harm or further pain. So that's one thing. But then, are you more likely to experience pain in the future if you have been in pain for a long time? Yes. I mean, at a local, specific, nociceptive receptor level, we are going to build some amount of The longer a person has been in pain, the more likely that nerve ending is to be stimulated with lower and lower and lower thresholds of stimuli. So that biological factor, and this is actually a really good chance to talk about, there's a Keith Smart, he talks about these three different divisions or types of pain in an individual. And this comes from his work on the mature organism, if people wanted to look it up. But there's considered to be local nociceptive pain, peripheral neuropathic pain or nerve related pain, and then central or nociplastic pain. And what he would contend, and many people in pain science contend, is that any pain experience has contributors from all three of those different pain types at any one time. It's just the relative contribution of each portion is slightly smaller. So you think of a pie divided into chunks. Does this lifter in front of you have an issue where we poke it and it hurts? We apply stress to it, we take the stress off, it doesn't hurt as much. That's more local nociceptive. Does this person have such long-standing pain that the mechanical stimuli needed to trigger that pain experience has led to changes at the level of the spinal cord or the brain, where a little bit of a stimulus, even a non-noxious stimulus, is enough to provoke that pain too? That's a possibility too. So in Mike's case, having had pain off and on for so long, or during his bout of time where from, like Mike, you said 2014 to 2016, you're just repeatedly in pain again and again and again, right?
Yeah.
Yeah. I mean, that's going to have some effect on that nociplastic portion of his pain pie. So yeah.
Yeah, there was something, an example that keeps coming to mind through this conversation for me is, I guess, a little more background. When I was little, too little to remember, my dad, like a lot of people, bout of back pain and went to the doctor. And this being, the late 80s, and kind of given what our thoughts on things were at the time, the doctor told him, "Hey, you've got degenerative disc disease, and you're going to be in a wheelchair by the time you're 50." And that's it's rough to hear, from anybody. So, especially somebody in a position of authority,
Yes.
like you assume that doctors know what they're talking about. So, like, that was a profoundly negative experience for him. And, like, as we have these conversations and had these conversations over the years, I do wonder, like, how much of, like, my belief on about, like, how back pain works and stuff like that, um, how much of it is informed by beliefs that, I grew up with. But, like, I remember getting into lifting weights and, lifting weights that were heavier than anybody in my area, or, like, heavier than anybody was lifting that I knew. And I remember talking to my dad about it, like, how does my back not hurt from this? And he was like, "I don't know." And we just kind of went on, like, he didn't, like, impart that, but that was something I was thinking about even then, but did all sorts of things, some things stupid, some things injurious, but that never really triggered some sort of catastrophic loop, right?
Hmm.
Like, I'd hurt my back and stuff doing stupid human tricks and things like that, but then nothing caused a chronic problem until many, many years later. But I will say, like, it's interesting to contrast the experience. Like, I think about, like, what the experience was like for my dad when he went to the doctor versus, like, where I'm at now. That if I go to the gym and I hurt my back again, uh, which happens sometimes, like, it's not that it's not a big deal. Like, and it could be a big deal, but most of the time it's not. And most of the time I know how to navigate it. And it doesn't have to be a big scary thing. It's like, well, yeah, it sucks, and nobody likes to hurt, but I know what to do next. I know about how long these things take, and you go, ah, man, okay, well, I guess I'll do the thing now. And you go through a process, and it's gone a long way. I mean, to use kind of a definitely overused term, it's been a fairly empowering experience that I go, well, I don't really have to be afraid of this thing now. Like, I know what to do.
Well, but let's imagine that you have all these cognitive strategies that serve you well, and a series of professionals around you can give you, let's say, better information than your dad received back in the 80s. And to be clear, my dad received the same information. He used to go to a chiropractor down the road, and this isn't to throw chiropractors under the bus, but there's a wide variety of kind of treatment quality, I think, from different providers. And that provider was all too happy to tell him his spine was subluxed. There were different intervertebral variations. He needed multiple manipulations to keep coming back. And my dad felt great from those manipulations and kept coming back. So uh, let's assume that you are getting better quality care than your dad did, and you've got these robust psychological strategies in place. There's still something that is unique to you and your low back pain presentation that needs to be managed in a way that does not include wait for it to get better, train around it, it will get better, promoting movement optimism. That's, I guess, the point that I'm making. And I think the biggest evidence of that, and one thing I was thinking about over the last couple of days, is you began to quantify a very specific value called spinal shear for yourself. You came up with that organically. You started to understand the patterns for your unique low back pain experience, and you determined, when I put myself in positions that seem to put this kind of stress on my back, I am more likely to experience pain, right? That's not because
Yeah,
you
totally.
believe those things. No one had told you, oh my God, Mike, your spine is ready to explode. No one had said that to you. You just came up with that by being the kind of
Right.
person you are, who's a person who tracks data religiously and looks for patterns and trends and identifies those trends. That happened.
Definitely.
So, I mean, I think,
Well,
go ahead.
another anecdotal wrinkle here that we can throw in the mix. Earlier, I think before I took the competition break, um, we eventually got to a point where the therapist I was working with said, maybe it's time to get some imaging done. Maybe you should go get an MRI. And I really hand wrung over that for a long time because, even at the time, I'm like, look, I've been lifting weights for 20 years, and like we're probably not going to get good news from this, and and thinking
Yeah.
lots of the same thoughts that we would come, we would go through now, like 2016 wasn't that long. And, thinking like, does this really have any sort of effect on our treatment or anything like that, and kind of my inclination was to not get one. The combined nudging of the therapist and my wife meant that I went ahead and got one anyway. And honestly, it was way better news than I had any right to expect. Like what it showed was like one tiny bulge in one spot. And they were like, yeah, I'm not even sure that that would be causing the issues that you've got. Otherwise, totally healthy, totally good to go, you know? And I'm thinking like, well, that's unexpectedly good news. Now, if it was just that, then you would expect that to have a positive impact, right? Like,
Mhm.
shouldn't
Yeah.
that then have some sort of positive impact? Now, oh, it was all in my head anyway. It doesn't hurt anymore now because I've got this self-fulfilling belief.
The placebo
That was
effect of
not
the
the case.
MRI. Yeah.
Yeah.
Yeah. No, no.
Right. Yeah. That would have been great if that worked, but it didn't.
No, I had the same thing like back then when I got injured and I had a back injury. I also did a bunch of scans and they turned out to be, yeah, like they didn't show any tissue damage. So I was really confused because for me personally, knowing what the problem was would have helped a lot. But one thing that really got stuck with me was that my physiotherapist back then told me it doesn't really matter what the damages are because the rehab is going to be most likely the same. So we're just going to deal with what we have in front of us now, how you're going to respond to it over time, and then we'll see. Yeah, but it just felt like we were searching kind of in the dark because also like for you, Mike, it was even longer than for me. But if you're in pain for a few months, it feels like a very long time, and it just feels like no one really knows what we're doing. And yeah, but then afterwards, now I could say, yeah, it takes time, but that's not true. Because you really need to keep moving and you keep exploring on what works for you. And once it's not like once you find something that works for you, it clicks, and then the next session you're super good, it takes time
Yeah.
for a certain strategy that works for you, and all certain strategies. There's not only one thing maybe that contributes to it. So
Well, and I've noticed that like dealing with clients too, like it's so much harder, so much more uncomfortable to go through the experience when you don't know what's coming, you don't know what to expect and things like that. So, like I said, like for me at this point, I kind of know what the process is and how long it's going to take for myself, at least. I'm definitely not an expert on dealing with this in others, but I do try to relay some of that experience just to help set some expectations on what might be coming, because even if those expectations are incomplete or incorrect in some important ways, having something to look at and is better than just not knowing at all. Because when you don't know at all, your brain starts to weave together these stories and you worry about things that maybe you really have no right worrying about. So just having some sort of set of expectations is tremendously helpful.
And I think it goes down to like there's a clinician who practiced named Louis Gifford who talked about there are 4 habits that a healthcare provider, a clinician, in this case a physical therapist, should engage in with all their patients. They should answer those 4 questions to put the patient's mind at ease. It's what's wrong with me? So that's really, we got to be careful, right? We can't use words that harm. We can't nocebo our patients. What's wrong with me?
Sure.
Um, what are you going to do to help me? What can I do to help myself? And the last one, how long is it going to take? You got to answer those 4 questions in order to have that person feel reassured and to feel comfortable with what's going to happen through the course of care. And setting those expectations, even if those expectations are not time based for the how long is it going to take, sometimes they can be criteria based. I want to see you be able to do this. And when you're able to do this, I anticipate that it's only going to take this much longer, or this is going to be the next step that we're going to go to. And having that stepwise progression or criteria based progression helps a lot. But I think going
Yeah.
back to your initial point about like identifying spinal shear, or like I was making a point about spinal shear and you said your MRI was clean. Well, you know, I think that there's a term non-specific low back pain, and most of the research has shown no efficacy for one intervention versus another in treatment of this term, non-specific low back pain, which really means, well, we don't have a fracture or something really like an acute trauma to the back that can explain why this person is in this much pain. But I mean, there have been varying degrees of success with trying to classify patients by type of pain that they experience, basically the clinical manifestation, and then matching treatment to those patient types. And there used to be 4 main classifications. Now there are 3. Some of the classifications have not been validated at the highest levels, but the initial studies showed some promise. So it's a helpful mental model to kind of put a patient in a bucket and to try a treatment approach that might be more likely to work with this patient. Well, in some patients, they seem to do really, really well with certain criteria when we crack their back. And we do a high velocity, low amplitude thrust manipulation like a chiropractor would do. And that relieves a lot of their pain, improves their function in a short period of time, but they have to meet certain diagnostic criteria. Then there's a whole camp of people that seem to do well when they are asked to move repeatedly in a certain direction. And that direction is called their directional preference or repeated motion or specific motion. It depends on the terminology involved there. And then the third camp is people who benefit from what was commonly called lumbar stabilization, like core training, so to speak. And those people do really well with bracing strategies, tightening strategies. And there are a whole bunch of unhelpful narratives that came out of flawed research on EMG data with respect to the transverse abdominis. And that's a trigger word for a lot of people. Transverse abdominis, oh no, don't use that word. But, using some type of core stave, and I'll always put it in quotes, core stave approach makes these patients so much better, right? So trying to match the intervention to one of these 3 main buckets seems to yield better outcomes. And to some extent, that's taking into account the patient's specific presentation in front of you and not ignoring it, not saying, well, we really don't know about anything. So we're just going to wait for it to get better, train around it. It'll be fine.
Yeah, you know what this reminds me of
What-
is when we would talk about strength development and do you get stronger? There's a big specificity bias, especially if you go back a few years, this really worked its way into powerlifting culture in a really big way as well, and to the point where if you look at common training programs, especially like through the 20 teens,
Mhm.
um, it was very much about high specificity of movement, high frequency of movement, pushing lots of volume through very specific exercises. So if you want to get better at squats, you do lots of squats. You don't do pin squats. You don't do safety bar squats because that's not specific, you know. And lots of these people like would kind of self-identify as like evidence-based types, uh, and so like they want to lean on research. Like, why would I include something like pause squats? Why would I include any of these other exercises? What evidence is there to support it? And there really wasn't any. There wasn't too much counter evidence either. Um, there's a little bit, uh, but if you just think about, if we think that not everybody is going to respond to the same set of assistance exercises, there's a varied response. Some people respond favorably to SSB. Some people respond, not favorably to SSB. So it's just logical that you will see a population wide specificity bias, especially if we're looking short term through generally people that aren't really working around any sort of external factors or anything like that. So I think it makes sense. And I thought, like, well, how would you even study that if you wanted to? You would need to come up with some sort of way of classifying people based on a weakness analysis and or something to that extent. And how would you even conduct that? Like it, there's so many steps to even be able to study it well
Mhm.
that we're just not anywhere close to that. But this is a really good example of like an absence of evidence just literally being not knowing. There is a truth there, and it just has not been adequately studied, so you couldn't say in either direction. Now, maybe you make a case, well, if you don't know, you lean on what you do know and
Mhm.
high specificity. But that's where we come back to clinical practice being a thing. Like if you look at, again, trends, population wide trends in training, what we as a community found through this is like, yeah, that works for a while, but it also beats people up, and eventually after a couple of years people get injured, sometimes career endingly. So people have backed off of that and include more accessory work now, and in fact, to a large extent, include lots of accessory work. And I mean, this veers into a whole other discussion about like populations. That now there's a new generation of lifters, and I don't mean this disparagingly at all, but the work tolerance in general has changed dramatically.
Yeah.
Um, it just has, and you know, it wouldn't make sense to apply the same training interventions and hope that they still work. You've got to treat the athlete where they're at right now. And I can't help but think like that has to apply to other things too. And I see a big parallel between the accessory rationale to what you're talking about in terms of pain management as well.
Yeah, but you have a method by which you assess the efficacy of your interventions, multiple methods, but really the simplest is um, athlete fatigue, that what they're telling you, and then what the E1RM is doing, right? Now, let's imagine in that case that you're a provider in some ways. You're more of a provider than I think almost any other strength coach I've, digested the material for. Like you're very much like a clinician, and I see those parallels too. You sit down with your patient. So let's say you had that non-specific effect of the provider mediated placebo effect. There's good evidence to suggest that just because I wear a white lab coat or something with my name on it and I come in and I tell you what to do, um, you are going to get better just because I told you to do something. There's that non-specific effect. You as a strength coach, reputable, world record holder, all these things, You come in and tell someone to do it, they're probably going to get stronger off the intervention you provide them, right? That E1RM is going to change. Can you imagine me telling you, you know what, Mike, I don't think you should use E1RM anymore because your standing within the community artificially biases lifters E1RM up when you coach them, right? But that's true, right? That does happen. But let's imagine the
Well,
clinical side, the same thing happens to me because I come in and I try an intervention and the patient goes, "Oh my God, that feels so much better. Yeah, I'm actually able to lift more weight now, or I'm able to bend over and tie my shoes and I don't have any pain now." There's a community who would say, because of the non-specific effect here, because of the provider-mediated placebo effect that you have on that patient, I can't believe anything that you've now achieved in that session via your test retest methodology. So, I mean, you
right.
have to have some
So,
system, right?
well, I mean, it's funny the difference, right? Because a power lifter will seek that out even, you know, like you join a team and there's hype around joining that team, and there's like this anticipation of improvement and a lot of excitement and energy around it. That's good, you know. And I mean, I understand that these things are different, and if you're going to, extrapolate those lessons learned to a broader population, yeah, sure. Like epistemology is still important. Yeah, no argument. But even from an injured patient perspective, like the thing that they care about is making it better, and if you're like, well, I can help you, but it's only going to be placebo. Like, well, I don't care. Just make the pain stop hurting, right?
Mhm.
So, like, I
I
Well,
think
think
well,
that
but I would
there was another
argue,
thing I
I
was
guess
going to go
maybe
for.
the position I'm coming from is untenable, and with time and wisdom and growth, I'll come to completely refute here, and the internet will have to be scrubbed of all the things I say right now. But I guess what I see is there's a portion of the improvement in pain that comes from that placebo effect. There's a portion that comes from the patient expectations. There's a portion that comes from the environment, but there's still a little chunk left over for the specificity of the intervention. And if you doubt that, I would ask you, and maybe this is a straw man argument. I don't know if it is, but I would ask you in, let's say, a vast majority of acute lumbar radiculopathy or cervical radiculopathy patients. Let's just take cervical because it's less familiar to people. And if you get a person with a pinched nerve, I hate that term, but an irritated nerve in the neck for whatever reason, you ask them to turn their head to the same side, bend their head to the same side, or extend their neck back. You tell me whether the pain they experience down the arm is real to them or not, or is mediated by local mechanical tension or not. It lights them up, right? In the majority of patients, it goes down their arm. They hurt like crazy. They say, get me out of that position as fast as possible. So there's some specificity needed here, and there's some specificity of intervention, I think, that can alleviate that pain that is not just placebo. That's all I'm making a claim for.
Gabby, if I can interject a quick anecdote here. This cuts the other direction too. Nathan, I don't know if I've told you this before, but last year, when we talked about this in the past, where last year I was prepping for nationals, I injured myself prior to competing a couple weeks out, and like I had a consultation with you where we noticed some things, and you had me do some exercises, helped my reduce my pain immediately. So if I think back to that experience, right? uh, We were doing this consultation, and you asked me to do some different movements. This hurts, that doesn't hurt. This makes it better, that makes it worse. These kinds of things. And then you said to do. Forgive me for not knowing names of these exercises and stuff, but we did like a lateral shift correction thing where I was like leaning against the wall, and this was supposed to provide some kind of immediate relief.
Sure.
I'm standing there like leaning against the wall, and I'm thinking, yeah, this isn't going to work, because all the things that I had come to understand up to this point. So like, yeah, there is the authority component in many cases, right? You have somebody in a position of authority and they're saying, hey, do this will help. But then that's not always true, right? Like, because I was standing there going, yeah, this isn't going to work. Or if it works, it'll be like maybe a tiny bit within the bound of like it's difficult to tell, but I just kind of want to be generally positive, right? No, it was not that. When I actually did it, I was literally surprised by how big the difference was, you know? And I don't know, that's a pretty powerful experience too, Mike Zordos talked about this years back. There was some research that they did on static stretching.
Mhm.
Take a whole bunch of people out to a track, put some people through a static stretching warm up, put some people through a dynamic warm up, and measure their time for whatever it was, the 100 meters or
Mhm.
whatever. And if you ask people what they believed at the time, uh, people believed that static stretching would be better. You were supposed to stretch before you worked out. So the the momentum of belief was strongly in favor of static stretching, but that's not what they found. They found that the dynamic stretching group, the dynamic warm up group, uh, outperformed, did better. And I remember he always would hold that up as like, see, like placebo effect is a thing, but that can't be everything. Like, some things do have effects outside of that, right? That's that's what comes to mind for me here.
I
Yeah.
think
Also, when
that's a.
sorry,
Go ahead, Gabby. Sorry, I didn't mean to cut you off.
sorry. Also, when we're talking about placebo effect or just finding quick solutions, of course, when you have a patient, like the patient just wants to get out of pain, you want to help them, but you also want to help them long term. Let's say, for example, when it comes to massages, of course, sometimes massages they can give you a quick pain relief, but then what comes afterwards? So I think by now it's really nice that rehab has shifted to this sort of movement where we're really focused on teaching movements and just incorporating this into patients' life because it's really important that people in general move more since that's something that general population baseline struggles with. And I think also as strength coaches, something that I see often is when when our athletes they start to rehab, they don't feel pain in training anymore. Then after some time, we kind of run against the wall. So we we get to a point like in the beginning, maybe we're training with higher volume, lower loads because they can't tolerate higher loads. And then we get to a point where, okay, pain decreases, we can increase the loads in training. But then it quickly shifts over to the other extreme where, okay, if we are working now with higher loads, then afterwards the backups, for example, will suffer because they just can't tolerate any more volume. Um, and then it feels like we kind of run against the wall because where do we progress from there on?
I mean, this makes me think, Gabby, the same way. Like, you don't want to breed dependency on techniques. And this is where narrative comes down to. It's like, um, oh my God, I can only go to Nathan Dailey because he only knows the unique interplay between the vertebrae in my spine and their unique movements according to Freud's laws. And therefore he can suggest a way to put it back in play. It's crap, right? We don't want that. We want Greg Lehman's, movement optimism. We want patients to be optimistic about their ability to recover and to use strategies in the short term that alleviate their pain, but allow them to get back to training, to do so in an intelligent manner, to build up slowly over time. Um, I think when I tried so story time. I came out of school in the Army. For people who don't know, I was trained in Army Baylor's program. I happen to be wearing the T-shirt today, but I was down at Fort Sam Houston in the schoolhouse, and I came out of school 2.5 years of training, um, ready to go on my first assignment, and I'd been taught very heavily within the old school biomedical and manual therapy model, which said, nope, you better remove L4 on L5 or you're not going to get the desired effect in the low back. You better mobilize that level, right? But I came out and I said, wait a second, this doesn't make any sense. I'm digesting a lot of this additional content that's coming out there or that's coming out. And I decided I was going to try to treat people with movement, with regressions, with progressions, with careful education, with encouragement to stay active, to manage lifestyle factors. And those things are very important. And you would say, okay, this is likely to work because of the population I'm working with. I have a lot of young, fit, healthy individuals for the most part. I mean, there are exceptions, but on a population level, I have the advantage of working with this group of people, but yet I could not treat a huge subset of the patients that were coming to me with that approach. They were so in pain. They were so unable to move. They had a lot of unhelpful narratives. So the patient education piece still had to be there. But there had to be some strategy to relieve that pain in the short term too, or to understand their particular sensitizing activities and to provide them with some pain relief in the short term by matching interventions to their presentation. So I started to come more back towards the middle instead of just living at one extreme. So I think that there's a role for movement optimism, but I think that we need to try to alleviate pain for those people who have quite a bit of pain and for which movement is not the right approach, first off.
Yeah. And I have a relative who was dealing with some pain issues. Eventually, she got prescribed physical therapy. Goes to the physical therapist, and in my judgment, there was kind of a failure to have this kind of conversation because she ended up walking out of her physical therapy appointment because she didn't see how they were going to fix things, and it looked to her like she was going to have to come back continuously. And and through having conversations with her, that was probably a mistake. It seemed like a communication problem primarily, but then there are lots of things through which, from where I sit. I mean, I'm obviously not a physical therapist, but I do work next to them quite a bit. For lots of years, it's been like a profession that I refer to quite a bit. So I see what is done. And, well, they often help people in these situations, right? So, yeah, just to say that like that type of communication matters a lot, and it's fine that there are population differences, and what you have to do to help uh, an athlete get back to performance must be vastly different than what you have to do to help somebody who's maybe 100 pounds overweight and dealing with some sort of chronic thing and has confounding health issues like that. I can't imagine how different those two scenarios have to be. You know, of course, the treatment intervention must be vastly different as well.
I think your entry point sometimes has to be different, but sometimes it's very similar. The similar negative beliefs about their pain experience, similar fears of movement, um, proving to that individual that movement is not painful, but maybe doing so with more passive type interventions that seek to move the joint in the direction you eventually want them to move, which is, let's say, lumbar flexion or left rotation for a left sided neck and arm pain. Um, but I really think that it's important in those early stages not to have negative experiences. And those negative experiences can really be like, okay, this provider didn't listen to what I expected, going back to that evidence based stool, right? I expected to have
Right.
hands placed on my neck. I expected to have an assessment of my range of motion and what produces pain. Meeting those patient expectations is important that you don't have that negative experience. And I think the negative experience also could be, well, this provider didn't really listen to what movements caused me pain. And they asked me to do those movements again. And I left feeling in more pain than when I came in. That's another negative experience. I wouldn't go back to someone who caused me more pain. And then the last one is, well, they told me I'm in pain because X, Y, and Z pathoanatomic diagnosis. They've never seen a back like this. This is the back of an 80-year-old. Oh my God, how are you not in a wheelchair? Those sorts of things. Those are all things to be avoided, I think, on that first session. And we have to really, as providers, avoid doing that with our patients.
You could probably fill a book with the differences, I would imagine.
Yeah.
Like other things that come to mind, we're talking about movement optimism and kind of building into that. That makes sense, especially if you're trying to restore some sort of athletic function. If you've got a sedentary population or a sedentary patient, rather, that type of thing where even just like some volume of getting up out of a chair could cause muscular soreness, which isn't by itself a bad thing. But if you have somebody who doesn't know what that feels like, then they can interpret that as an injury. And that sounds crazy, but I've absolutely had that happen in a training space. Like, oh, hey, I lifted weights, but now my legs are injured. No, they're not injured. You're just sore, and you don't know the difference. You know. And I would imagine that that has to be something to be concerned with as well.
Yeah. I mean, I think you talked about that with Jordan too on podcast back in 2019. You talked about that classification of injury really comes down to um, the forced stopping of an activity due to the patient's perception in some way. So if they think that DOMS is severe enough to stop them from training or that something is seriously wrong with them, it qualifies to some extent as an injury.
Yeah, it confounds everything, makes it a lot harder to
Define,
get
yes.
to.
Well, I mean, I think what I just want to, like, I don't know if we're nearing the end of the available time, but I want to emphasize that I'm not trying to swing us back to the days of bygone where it was like, well, I need to mobilize at this segment because this segment in your spine is stuck. And the only way to get you moving better is because we're mobilizing at this specific segment. All I'm proposing is a specificity or a specific approach to the patient or the lifter in front of you that takes into account what they're experiencing and then also seeks to provide movements that maybe are matched to that presentation and not to another person that might have a better probability of getting the patient better. And really, just at the end of the day, making sure that any provider you go to has a system in place that assesses change over time in pain and function and is detailed enough to pick up on those changes over time. Because if you're just throwing exercises at a person because you saw them on Instagram or your professor told you they were great, I, I don't think you're going to get the outcomes you're looking for as a clinician, and the patients are not going to get those outcomes either.
And I mean, I would say that you guys spoke earlier about how, like, I viewed part of this process and familiarity with it as being empowering. And I think it's important to point out that a big part of that is the understanding of load management, exposure therapy kind of approach that has been an enormous tool, enormous benefit for me personally and for my athletes as well. Totally agree with you. It's definitely not about going back to the way things were, but I do wonder if sometimes maybe we haven't gone a little bit too far. That I think that there is some sort of physical cause somewhere. Like there has to be a something that's causing these things, or multiple issues that are causing pain experiences and things like that. And it can't all relate to simply psychology or simply, that can't be the only thing going. This is where I end up.
Yeah, and the need to modify technique maybe because local tissues are being sensitized by a particular technique. Um, I guess selection, right? You are in pain, and doing something with a rounded back feels worse, and doing something with a straighter back feels better. I mean, maybe we can't make any claims as to the risk of injury of those specific tissues, or I can't on the front end when the person isn't injured. But I sure as hell can tell you that one position is going to hurt that person more than another after I've done a clinical exam on that person, right?
Yeah,
Yeah.
yeah. I mean, this at the risk of taking us around again. That is another thing that kind of points to there needing to be some mechanical something under the hood here. That why else would you see, shoulder injuries in pitchers? You see tendencies toward certain injuries given certain types of activity. Powerlifters tend to have pain. Back pain tends to be the biggest thing that I see, but also shoulders and things like that. Weightlifters my understanding is tends to be knees and elbows, probably backs as well in weightlifting, but different activities tend to see different types of injury being more common or less common. I mean, you can't explain that if it's just bad phone calls.
I think a very simple thought that just comes to mind is if you do something very often, there's a risk that, yeah, you get injured. Just as if you would drive a
Crazy talk,
car.
right?
If you drive a car,
Yes.
you run the risk that you're going to have an accident. But if
Yes.
you never move, you also run the risk that you're going to develop pain in the long term.
Yeah. I mean, we talk about this all the time, the health-related risks of inactivity. Like, there are real risks associated with never leaving the house. But if we look at the injury literature too, there seems to be, there's a reason why, I'm not going to use names, there's a reason why Nordic hamstring curls became so popular. It was because in a very certain population, specific population, soccer players who often reach to extend toward a ball, stretching their hamstrings rapidly, we see a reduced risk of injury in multiple studies in soccer players when they do Nordic hamstring curls, because surprise, surprise, their hamstrings are disproportionately stressed by that activity, right? And building stronger hamstrings might reduce the risk of sustaining some type of injury in that regard. It's not that Nordics cure knee pain. It's that Nordics are specifically strengthening potentially a tissue that is likely to get injured for certain athletes.
Yeah. Nathan, appreciate your time, man. And I think we probably could go round on
Yep.
this, and we'll have to do that again sometime. But again, I appreciate your time and thanks for your balanced viewpoint. And thanks, Gaby, again. And thanks, everybody, for watching, and we'll see you next time. I hope you've enjoyed this conversation with Dr. Nathan Dailey. Now, at this point, you may be thinking, how do I get in touch with this guy? I've got some problem that I need some advice on, or something I've been working through with a client. In my opinion, the best way to get in touch with Dr. Nathan is going to be to go through the training lab. The RTS Training Lab has tons and tons of features. One of them is our office hours. Dr. Nathan regularly conducts office hours for the training lab. Members of the training lab get to show up to these live meetings. It's already included in your membership cost. So you just show up, you ask questions, you get advice, and you make use of that expertise. There's tons and tons of other features too. Like, to be honest, it feels kind of ridiculous when I look at all the benefits that are offered through an RTS Training Lab membership. That is definitely something I would highly recommend that you check out. If you want more information on it, you go to store.reactivetrainingsystems.com, and in the menu, you're going to find Training Lab, and that'll give you all the information that you need. Thanks again for watching. See you next time.